Well, it's an honor to be here at the UT San Antonio Health Center and to share some reflections on leveraging AI advances in healthcare in particular. So the next few minutes, I'll share some history, what I would refer to as the arc of innovation with AI, with a particular lens on AI in medicine. And then I'll touch on some key trends at the frontier that I think are very interesting and informative for all of us in this field, and then conclude with several opportunities and challenges ahead. So first I see AI, I like to start with a definition, right? You know, I like the definition that it's the study of computational mechanisms underlying thought and intelligent behavior. Now, in a document that kicked off the whole modern study of AI in 1955, the founders of the field said they were trying to find how to make machines solve kinds of problems now reserved for humans. Now, in 1959, just 3 years after the phrase AI was first used, I think it was conjured up by John McCarthy, who I spoke to about that term. But 3 years later, Robert Ledley and Lee Lusted wrote a foundational and remarkably prescient article on the reasoning foundations of medical diagnosis in Science magazine, talking about how combinations of logic, probability, and decision theory could aid our understanding of medical reasoning and the prospect of building computing systems that could help physicians with diagnosis and therapy. Now, that early focus on harnessing AI to enhance diagnostic accuracy is the longest lived and deepest aspiration for AI in medicine. So it's now such an exciting time for applications of AI advances in medicine. I just put up a little ontology. Of course, we can have a bigger ontology, categories like this. There are some many efforts going on in a great many areas of opportunity, from the use of AI in decision-making to population health, to biomedical research and science investigation to education. But that early focus on harnessing AI to enhance diagnostic accuracy is the longest lived and deepest aspiration for AI in medicine. And so I'm going to focus my comments today on that holy grail of AI in medicine, on directions with harnessing AI methods for boosting the quality and efficacy of clinical care. So there's been a great deal of work in AI for medical decision support over the decades, but most work until the early 90s was on handcrafted systems. In the late 1990s to today, a great deal of medical data became available, in part because of the digitalization of medicine with electronic health records. And that work, along with advances in machine learning, algorithmically, led to explorations of the use of machine learning to construct diagnostic and predictive models, and to connect these models directly to the hospital information systems to provide predictions based on fixed sets of evidence that were identified by the ML, machine learning algorithms, from the data, and then use it at runtime to make predictions. So, for example, the health record might give a whole bunch of possibilities, things to look at, tests and radiology imaging data and so on. And the algorithms would pick a set of things to look at, given a goal prediction. For example, in this case, one of our early pieces of work on predicting readmission under 30 days, when that was coming to the fore as a penalizable metric, shows you the things that came up as a predictive evidence here. You can run it in real time, and you can see how we did this study back in 2007, 2008. We're looking at this paper on data-driven decisions for reducing readmissions. Back in those days, when we submitted this to major journals in medicine, people thought we were like, how does this work? What are you talking about? What do you mean by machine learning? Things have changed, though. That system, that model underlied the readmissions manager, which we shipped worldwide in 2009, I think. And it ran with its own test and train and test algorithm at every site locally, because we couldn't make it portable given different demographics. Put up a probability of readmissions, it explained the information and so on. It was based on data originally from the Washington Hospital Center, a MedStar hospital in Washington, D.C. Now, one thing about classical machine learning, and I just was talking with Sambit about this at lunch, that we still yearn for in the modern world of AI is these models could be well calibrated, and they can give you well-characterized predictions with well-understood sensitivities and specificities, which you need for any kind of medical device, for example. So you can even operate at different thresholds here and understand what the trade-off between true positive rate, for example, and false positive rate will be in a hospital. We also did the same kind of modeling for the risk of C. diff being a hospital-associated infection, starting within 48 hours for patients to prioritize, for example, antimicrobial stewardship. The other really cool thing was when you had models that were well calibrated, you can build this pipeline of data to predictions to decisions and do a decision theoretic cost benefit model about allocating resources based on the model's predictive power at any hospital. Now, but 15 years ago, I mean, and the work I just talked about was ongoing in the early 2000s, and it continues to this day, and it's very promising, but eyes have been turning elsewhere, given the flashiness and the excitement about large-scale language models. So about 15 years ago, we hit an inflection point in AI, and I think it's clear that we've been riding on top of a fast-moving wave of innovation with deep neural models since then. And that wave has included reaching parity with humans on a number of challenging benchmarks in visual and language tasks. So around 2010, we started seeing the power of neural network models for applications like image-based diagnosis in medicine, spanning dermatology and radiology, running at expert levels for these tasks, where, for example, the AI could sort of highlight what it was looking at with a particular heuristic and making its recommendations. But importantly, over the last 4 years, coming on 5, we've been riding on yet another acceleration that I see, and I like to talk about as being an inflection upon an inflection. With the qualitative and quantitative capabilities we're seeing now with generative AI that are showing unexpected powers of generation, synthesis, and composition. The generative AI breakthrough have hinged on 2 powerful ideas, relatively straightforward, but they're clever. The first is the idea of self-supervision, where massive corporate like text sequences, represented by these squares here, or imagery, can be harnessed for training via a hide and seek procedure, where words or tokens, more generally, are randomly hidden by the system, and the system is asked to guess them and gets better and better with a scoring metric, capturing how often they can get the hidden tokens correct. This lets you use instead of looking for an expert to label data for you, you have the ground truth in front of you, and you hide the ground truth and train on massive corpora, much larger than we've trained on in the past. The second innovation is teaching a model what to attend to via an architecture named the transformer that is set up to allow models to learn what to look at across context, some before and after, but typically before, and broader model activations as it does a generation of the next tokens. In this case, the system is trying to predict what comes after learning to attend to context, what comes next. Let's talk now about key trends. The 2 concepts I showed you are at the root of key trends of the last 5 years, and these have great relevance to AI for healthcare applications. We'll look at several today here. First is the impressive power seen with increasing scale of compute and data. There's been a lot of excitement over the last few years with what you see coming out of these models that come with scale. Here's the data center where GPT-4 was birthed, just west of Des Moines, Iowa. And that data center had 10,000 GPUs and over 300,000 CPUs, and at the time was one of the biggest GPU clusters in history. But data centers like this are small now. We have much larger ones being built as industry competes and pursues capabilities with scale. So studies have demonstrated some classic papers that with scale, we see the rise of capabilities in language, mathematics, and programming tasks, for example, and with the sudden emergence of surprising abilities captured by the pops you see here on this graph, like learning to solve a new task from a handful of examples in a single interaction. But more generally, the rise of what I think is almost magical capabilities of abstraction, composition, and generalization. So my team was one of the first in the world to examine GPT-4 carefully as part of a request by OpenAI, help us understand this thing we just created. My team was responsible for safety and capability reviews. And we were all shocked in August of 2022 when we saw the general purpose powers of GPT-4 and the jump from GPT 3.5. For example, showing the ability to write a proof of the infinitude of primes as a poem, or to write computer programs in response to a prompt without specialized training like you see here. We were impressed with the ability to see effective responses to long, detailed prompts, such as this one here, asking the model to perform a set of complex visualization tasks. Now, much is being done now with these and other large generative models, but even deeper impact is on the horizon, and there's great application for building workflows for examining, in this case, biomedical data sets. But beyond the impressive powers that we saw with generalization and abstraction and code writing and poems, mathematical proofs inside of them, we've been seeing powers of specialist expertise in the generalist models. So we explored the power of the model for healthcare back in August of 2022, in that same month. And for example, here is looking at some really challenging diagnostic cases from the New England Journal of Medicine, the CPC cases here. And we're amazed at the ability of these models out of the box to address some of these most difficult challenges, as shown in this case of the diagnosis of babesiosis. It's a tick-borne parasitic infection caused by Babesia macroti for our parasitologists in the audience that know about that. I was also shocked by the ability of the model to solve medical competency exam questions. We showed right away that there was a big jump in GPT-4, including stellar performance on step 1, step 2, step 3 of the USMLE exam. I started to think about what I had to do to study for those exams back in the day. Another interesting trend is the shifting of the Pareto frontier. What I mean by that is with scale and other advances, we're seeing this trend of this accuracy, cost to compute frontier changing. So x-axis here is the total cost for computing a result. The y-axis is the accuracy. We're running on a very hard, big medical QA test set here. And if you look from the right, lower right, and head up to the upper left, you're seeing curves of what was possible at cost bottom, and it's a log scale, by the way, versus benefit accuracy, going from 2023 at the right to the middle, 2024, and now 2025. So you see right now, for a few dollars, you can run this whole gigantic corpus at higher accuracies than you could for $1,000 just a few years ago, and with lower accuracy. Another trend, now one of the hottest areas of research, is real-time or test-time reasoning. It turns out that this was the focus of my PhD dissertation in the late 80s, controlling meta-reasoning for Bayesian networks of the day. And I found myself sitting in meetings with OpenAI leads and at Microsoft talking about taking principles from 1989 and 1990 and applying them to control how we do runtime reasoning with these models with cost benefits. So you see on the left here is the power of the O1 model, one of the first real-time reasoning models that does chain of thought. And this is running on some challenging math problems as a function of training time, building bigger and bigger models. And on the right is what a smaller model does. You fix it and give it more and more test time compute. So it's a whole new dimension opened up. This first came out, it was internal, and everyone was like so excited. Like, we can't tell, it's all secret for a while, you know, between OpenAI and Microsoft, and we sort of rolled it out. It's great to see all the innovation happening around it. But it's not just graphs, right? This is the power of real-time reasoning showing up in medicine. So I gave a little whisper to my friends at Harvard and Stanford, my academic colleagues. I said, hey, one's coming out. Let's get ready to, let's get ready. I just said to see how well these runtime reasoning models do on medical hard cases here. And so we wrote a paper that's, if you look up the exuberant title, I wasn't that big fan of the title, Superhuman Performance on the Reasoning Tests of a Physician. It's still under peer review, but it's an archive. You can read about these examples. But what you see here is one example of the performance of O1 on a particular hard medical challenges used in medical education called NEJM healer cases, where O1's performance at the top here shows the performance of what's called the R-IDEA score. It's a psychometric score capturing the quality of clinical reasoning. And GPT-4 is right beneath it, just like, one notch down in model history, getting 47 out of 80, and meanwhile, O1's getting 78 out of 80 on these very hard cases. Another important trend, especially for AI methods in medicine, is multimodality. So multimodal models can bring medical language and imagery together to build joint representations. And of course, radiologists, for example, are not siloed into imagery or language. They look at both, and most people do on planet Earth. We're going to weave these pillars into clinical medicine into rich joint representations. An early example was our work on our team on what's called LavaMed. Pretty amazing. I mean, this was we took an open source model and then went out to PubMed and automatically scraped tens of millions of figure caption pairs, figure and caption, tens of millions, and fine-tuned this model. And all of a sudden you can talk to the model about things it's seeing. It's like we've given a visual cortex to the system by just post-training it to understand these pairs of figure caption. Now today we've access to multiple freely available models like Myra, which is available on Azure, which provides visual grounding with its analysis. It calls out automatically areas of attention as it talks about a radiograph, for example. It highlights them in different ways and calls things out. Now, another exciting trend or sub-trend in multimodality is multifunctional imaging. And I have to say, when I first saw the results of these models, it kind of blew my mind. So what happens in the training phase for these models is they're combining many biomedical imaging tasks, including across specialties. The same model is learning about pathology, radiology, endoscopy. It's also combining segmentation tasks, detection tasks, and recognition tasks. Almost like we're building like a visual cortex of a radiologist, but maybe one that was trained in residencies in many areas. So as an example, so this biomed parse is built from 82 major biomedical imaging tasks across 9 imaging modalities from over 1 million images that are tagged with segmentations and text labels, as highlighted by the chart with different colors showing different areas of medicine. So end users playing with this model, you can ask a large variety of questions to the same model. In this case, on the left, histology, and talking about where are the cancer cells and so on. On the right, brain imaging, same model. We're asking it to highlight a region where there's a pathology. And again, all in the same model. Something I would not have expected to see, I don't know, even a few years after the first GPT-4 ship, but certainly maybe not even in my lifetime. Another trend is the power seen with generalized cross-modality models. I notice I've changed from multimodal to cross-modality very deliberately. And these extend beyond language-centric tasks and beyond vision, where training and inference procedures bring together multiple layers of biomedical information. So one example of this work is a project called GigaPath, which was published last year in Nature. The project centered on training a multimodal model with over 150,000 pathology slides, along with genomic data linked to each slide, and cancer staging information linked to each slide. And the model shows at scale how you can boost the performance on doing cancer subtyping and mutation prediction just from the histology. Now, over the longer term, I believe that these cross-modal models can provide breakthrough approaches because they're weaving together different data sources, figuring out how they go together in mysterious ways that no AI scientist, I was talking with Savita about this, no AI scientist understands today. That's one of the differences between the Bayesian networks and the decision theory I spoke about earlier and today. We're working with models that we fundamentally are impressed by, that have some degree of characterizability, but we don't know how they work, which is an interesting challenge to AI scientists. Let's figure all this out, because if we know how these things work, we could probably do better with them. But in this case, I'm saying that what I view as possible in our near future is delivering ultra-personalized, ultra diagnosis, therapy design, and prediction of outcomes. You're building models at population scales that combine imagery, language, as well as the genomic, transcriptomic, proteomic, and rich phenotypic information. Talk now about another trend. People hear this phrase now a lot. agentic systems. We're seeing a rapid rise in what I would just say systems of models being used where the models or model calls are interacting with one another, provide a service or some rich set of capabilities. And we often refer to these multi-model calls or multi-agent systems as agentic systems. We have frameworks freely downloadable from my team, like Magentic One, that allow scientists and engineers to build more sophisticated problem solvers by defining what I would say sets of specialists or agents that take on independent roles, and then orchestrating these agents into larger multi-step planners and solvers. These agents act with different expertise, access to tools and data. So we were just finishing up Magentic One, and we didn't even have a name yet. And I was going off to give a AAAS lecture called the Omen Lecture last year. And I wanted to do a quick demo. So I worked with a couple of my engineering friends. I said, this might be a kind of fun demo for a scientific group. We called it the Biomedical Research Assistant, built on Magentic One. This is an example aimed at providing scientists someday as a prototype with a biomedical research tool. The system is powered by 5 separate agents, including a web surfer agent, a bioscience research reviewer, and an orchestrator. Talk about what these systems, these components all do. Let me show you how this actually works. It's kind of fun to look at, and it'll give you a sense for the possibilities. So the idea basically is to have an agent or the system collect and read relevant literature given a question or prompt, assess the scientific rigor of each article, and I could talk about that. It's a whole agent in itself, double-blinded, how N equals what exactly, who funded it, and so on. Synthesize a holistic report from all the papers, weighting the little scale here, the veracity and the trust in the paper with the content. Go up and identify contradictions and disputes among these papers, for example, and then propose forward steps with experiments and studies. So, for example, what is the role of telomere length in cellular aging and senescence? What's the latest on that? Anybody know? I mean, it's unclear. It was unclear to me when I asked this question. So let's read and collect relevant literature, begin to assess scientific rigor. You see here a little snippet of the long report coming out on each article. Pull it all together and give me a holistic report weighing the veracity of each article. Identify contradictions and disputes. Isn't that nice to know about? And then propose whole new steps. How can we resolve these disputes? What's the next step on the frontier, for example? So that was one of my first agent projects for my personal I was involved with. But then in the last several months, we've gotten involved in several different agent-based projects. One is on agents in diagnosis. We went back to the New England Journal of Medicine, these hard CPC cases. We just published, right now it's under peer review, but we just published to archive the results of this paper, the paper on these results. And so what we did here is, again, looking at these hard New England Journal of Medicine CPC cases. Typically, it's like, in this case, for example, a 12 pages long discussion with a presentation, with lab tests, imaging studies, other information, finally getting to sometimes a very rare diagnosis. This was a 53-year-old woman with shortness of breath on exercise, kind of a mystery. And these CPC cases are very interesting because if you are familiar with them, you read them, and it's like they actually will bring together like a panel of different physicians and independently and together, and they all kind of scratch their heads and they think about the case and they talk about what the findings are and so on. So we employed a system we call the DX orchestrator, diagnostic orchestrator, that employs 5 agents in a sequential diagnostic setting that work to get to the final diagnosis while managing the costs of the tests. So they're looking at minimizing costs, but getting to the answer, efficaciousness, back to my earlier comments. What are the 5 agents? Hypothesis agent maintains a probability rank differential diagnosis. Test chooser agent selects tests that maximally discriminate among hypotheses. Challenger agent continue to act as devil's advocate by identifying anchoring bias, contradictory evidence, proposed tests that could rule out leading diagnosis, and so on. Stewardship agent, cost consciousness, advocates for cheaper alternative. Sounds like an insurance company. When diagnostically equivalent tests are there for information value, and vetoes low yield, expensive tests, like saying, come on, that's not going to tell us very much. And a checklist agent does quality control, and it looks at test names coming out so the system knows how to collaborate with a database and so on. All right, let's look at another Pareto frontier curve. At the bottom is over 250 CPC, these are the hard cases, is the cost. What was the mean total test cost? Get to the answer of the 250 cases. And on the y-axis is the diagnostic accuracy reached across the 250 cases. The blue shows you here the output for different configurations of the system. Here you see on the curve, you see, for example, if we just gave the DX orchestrator system an $8,000 budget max, it's kind of operating at about 80% accuracy and running about $2,500 of testing, and so on. The pink and plus signs are the general practitioners we brought in to take the same test. The plus sign is the mean on both the diagnostic accuracy on these hard tests and the costs of tests being ordered by human physicians. Now, we got a lot of blowback on this from some colleagues who said, wait a minute, you didn't let the human beings have access to the web? We said, nope, closed book. This is because these days, if you go to the web, you can't stop AI from creeping in, right? You go to a Google search, there's the AI system. So, but we decided to, in our next rev of the article, give folks access to some of the standard medical tools that are used in practice. And I have to say that, yes, I don't have the data here, but the plus sign does move up a bit, but I think it moves to the right too. And it still is way dominated by this AI system here. Now, on another agentic system for healthcare that our team is really deeply immersed in right now, working with collaborators around the country, including Dr. Kumar Sharma at UTSA, he's using this framework, from my understanding, for looking at liver and renal diseases. But we originally built the Healthcare Agent Orchestrator for helping with tumor board meetings. For me, in medical school, I went back to after my PhD work, it took a few years. I was blown away by the wonders of the collaborative or the collective intelligence I saw at tumor board meetings. So what happens at these meetings is very difficult cancer cases come to the fore, and a board of specialists, all the relevant information, the pathologist, the surgeon, the radiation oncologist, the oncologist, the social worker, the family, of course, the patient and the family will sit together, and you sit in a room. In the old days, now, as we see here, it's Teams or Zoom, but you sit in a room and a slideshow is presented, radiology images showing the cancer progression, the histology, what are we seeing here, the stains, response to therapies, and so on. So it's complicated meetings right now. This shows our collaborators at Stanford right now. We started working with Stanford originally on this, where literally we have IT, we woven together, I should say weave together our IT groups. So we're trying to understand better how to build a better healthcare agent orchestrator. So there's obviously a great deal of information across time with complex patients, with input from multiple specialties. And we explored the use. The first use has been how the HAO system can be used to pull together information to prepare clinicians for a productive tumor board meeting. If an oncologist or resident is assigned to prepare a tumor board meeting, it's a big deal. There's lots of information, history, notes to look through, and lots of patient charts and so on. And so what the system does here is you can actually call in different agents by name. Patient history summarization agent, radiology agent, pathology agent, staging agent, literature review agent, clinical trials agent, and so on. For example, in this case, David Power, anonymized name here, wrestling with prostate cancer, localized to seminal vesicles. We bring the system in, and it basically we literally explicitly with a command prompt add experts to the discussion from the system, and then the system goes out and summarizes things that are per relevancy, per its training and its prompting, to create supportive materials for helping with better decisions. So the last topic I want to talk about today on trends is resonates with the theme of this meeting on augmenting human intelligence. We have much to do in the realm to build AI systems that nurture and support human decision-making and human agency, and that work to augment our intellect. And we're still in the very earliest days of this work, unfortunately, because it's such an important topic area. I thought I would just tell a quick story about a recent study and its background here. So in a recent study that I collaborated on as co-author, based at Stanford, we set up a randomized clinical trial that included 50 physicians in family medicine, internal medicine, and emergency medicine at multiple sites, including Stanford, Beth Israel, Deaconess Boston, and University of Virginia. The clinicians were randomized into two groups, one using the LLM, in addition to conventional diagnostic resources, the other only conventional resources, books, search, and so on. And we gave them 6 hard, curated clinical vignettes, patient presentation, labs, and so on. The finding is very intriguing here. The LLM did not significantly enhance the diagnostic reasoning performance compared with the availability of only conventional resources here. So conventional resource only, this is a JAMA Network Open publication here, 74%, using Gen AI, 76%, which I found very striking. So I want to show this again more closely. He's like, show me that more closely, right? So using Gen AI, the physicians got 76% on a rubric that close to 100%. Conventional only, 74%. Are you ready? Take a deep breath. Gen AI alone. Gen AI alone. This led to all sorts of crazy headlines. New York Times. AI chatbots, the doctors are dying. You know, it's like everyone got upset. Well, the line that I wrote in the paper, among other lines that I said, let's get this line in there. The LLM alone outperforming physicians really indicates that further development in human-computer interaction is needed to realize the potential of AI in clinical decision support systems. You'd all agree, right? So we went back to the drawing board and working with Celine Everett, Ryan Bunning, two medical students, well, actually PhD student and a medical student for the last several months. I said, let's leave the big team behind. Let's work as a threesome here. So in a follow-on study, we were very careful to consider notions of complementarity between humans and machines, a mix of initiatives, and working on grounding. This is the seeking mutual understanding between human and machine. Now, I've spent a number of years publishing on core papers in this space, looking at the principles, decision theory, controlling who does what when with teams, and we haven't really brought this to medicine yet. So in our paper, which is also under review right now, hopefully be out soon, on medRxiv, called From Tool to Teammate, where the last study was on tool. Now we're going to teammate on a randomized controlled trial of clinician AI collaborative workflows for diagnosis. We set out in this way. We said, let's try different workflows. Let's try AI as first opinion. AI sees the vignette, generates its diagnoses as well as next best test to do and final call on diagnosis. The clinician looks at that, thinks about it, comes up with his or her own assessment. Then we've asked the system to take both sources of information and weave together both inputs, display what came from whom. The AI and clinician both agreed on polycythemia vera. And also, as a comment, critique each one of these things here now. Only the clinician thought EPO secreting tumor. And then the AI system says, but it has a little argumentation going. EPO makes this unlikely. However, I guess rare analogs make it possible, but less likely, and so on. That's one workflow. The other is, by the way, you can imagine at some point, the final diagnosis after the physician looks at this weave. They now work with the patient, right? It's not the AI system, of course. Let's switch things around. Doctor goes first and then shares his or her findings with the AI. AI goes second through the weave. So what we found now is going from the last paper to now, the humans are doing different things, but on average, there's insignificant difference between the AI and the human expertise using the system at this point. And they're not copying the answers from the AI system. So it's interesting. So there's much to do, and we're still analyzing the details of how the diagnostic performance of clinicians using conventional resources, which is the middle column here. This is like what you see here is 6 cases of the vignettes. The middle column shows the scores that clinicians came up with how many of them out of the full battery came up with like a top score versus second top, third top. These were actionable scores, a portion of the scores. But the middle is the conventional. And then we have the second opinion doctors acting after AI on the right-hand column here. So you see, interestingly, some of the low scores are going in the Sankey plot are going up after exposure to AI. But interestingly, some are coming down. Isn't that interesting? So what we're trying to do here, given the theme of this gathering today on augmentation, there is a rich structural fabric between machines and humans that design principles and study can help us better understand. So with that, let me just say that we have many challenges and opportunities ahead. I like to think small c, big O, being reasonable. I would say that at the top of the list for me is human AI collaboration. Let's figure that out. Let's think about human agency. And by the way, figuring that out, I think, is not just technical, it's socio-technical. Like how is medicine going to evolve? What does it mean to be a physician? What residency program do medical students select and why? What do they expect they'll be doing in those roles? We need, per my conversation with Sambit earlier, we need to figure out how to, on this new dark matter called deep neural networks, to figure out how to make them reliable, how to trust them, and how to evaluate them well. Then thinking about it's never the case that you have a box sitting around coming out of UTSA computer science lab that's going to be delivered to the hospital and have it be used or trusted. We have to think about workflow integration and spelled more correctly here, a diffusion model of how do you diffuse these technologies into people, society, and organizations. And we have a lot of work to do on norms, ethics, and regulation. I was involved in this interesting National Academy of Medicine report called AI Code of Conduct. I'd love you to take a look at that. We try to make it at the right level of abstraction to make sense and not be overwrought with regulatory kind of suggestion. So I want to end by calling out attention to a set of reflections captured in an edited piece that I put together named the AI Anthology a couple of years ago. We did this AI Anthology before GPT-4 was public in November of 2022. I said, oh my God, I can't sit on this model. Can I get permission? I know it's all top secret. Can I get permission to share the model out with experts across fields? Just get their reactions to this. You'll see it's a pretty broad span of experts from across the world, including across the sectors, Marshall McNutt, National Academy of Science, the Dean of Engineering at Duke, psychologists, psychiatrists, mathematicians, physicists. But I want to say that there's 4 folks I asked from the medical area. I gave them this piece of magic to look at and asked them to write a kind of 2 to 3 page essay, something, a 4-page essay. Just what I asked them to do was give us your reactions to what you're seeing. And please, how can we harness this for the benefit of humankind? What do we need to do? And so these 4 folks here, Natalie, Trevor, and Robert commented. I want to just end with Bob Wachter's comments. He was then chief of medicine at UCSF. He titled his essay, "Will GPT-4," but you can put, will large language model be the technology that finally transforms healthcare for the better? Will future versions of GPT-4 be the killer app that finally allows healthcare to deliver new levels of quality, safety, and equity, and improve patient and provider experiences? That's how he ended. And will it generate efficiencies that allow our healthcare system to operate at a cost that doesn't bankrupt businesses, government, and patients? I believe the answer will be yes, but it exceeds the capacity of this particular human to predict whether these benefits will be seen in 2 years or 20. So I think we can all come together to bring many of these possibilities for enhanced healthcare sooner rather than later. Thank you.